being with us.
Yep. Hello, everyone. Bonoziwa. My name is Adrian. I'm a consultant at King's College Hospital in London. It's a real pleasure to be in your country. It's the first time I've been to Moldova. I've been very impressed so far. And the topic of my talk is deresuscitation. And I think it follows on very nicely from what the first two speakers have talked about. I'm going to talk to you about the what, how, and when. I think it's fair to say as an opening statement is that if you think about what we do in anesthesia and intensive care practice, and if you think about what you've heard in the first two talks that we've had in this session, a lot of what we do when it comes to fluids and hemodynamics revolves around giving fluids. What is the best way to give fluids? What are the parameters that we are using to guide fluid responsiveness? What are our markers of success? What fluids to give, how quickly to give them, so on and so forth. So the deresuscitation phase, or the latter phases of fluid management, is often neglected, both from a clinical perspective and research perspective. But we all know fluids are drugs. Like all drugs, they have got their indication and contraindication. There's a right time to give it and a wrong time to give it. There's a right amount, there's a wrong amount. We also know that there's a wealth of literature out there that shows under a variety of different settings that we see in anesthesia and in critical care, that if the patient remains in positive fluid balance after about 72 hours of their stay, they do badly. They do worse from a mortality perspective. They do worse from a length of stay perspective, ICU stay, ventilation, so on and so forth. So we know too much fluid is a bad thing. The second speaker has kindly laid out the ROSE sort of acronym for you. So resuscitation, optimization, stabilization, evacuation. It's a cognitive conceptual model. And the theory is that through the different phases, the patients are doing different things in their journey through their critical illness. And like I said at the start, most of what we do, both from a clinical and research perspective, focus on the first two, not so much on the last one, okay? Probably the most important take-home message I have for you today is that just because you are fluid responsive doesn't mean you need fluids. And the problem with a lot of the earlier trials of goal-directed therapy, etc., is that we just kept giving fluids till the patient became unresponsive. So if we take all of you here are almost certainly going to be fluid responsive if we do tests and so on and so forth. But I will also wager a good amount of money that your lactate will be fine, your blood pressure is okay, your kidney's okay, and you are somewhat cerebrating given that it's 4 o'clock in the afternoon now, okay? So it doesn't help that the latter phases of clinical practice or research, the terms overlap. So fluid overload, fluid pulmonary edema, fluid accumulation, they all mean similar things, but there's a lack of precision around their definition. So when we talk about fluid excess, what do we mean? Are we talking about the same thing? So when it comes to deresuscitation, the literature now, again, remains nebulous, but seems to be an agreement that there is a difference between deresuscitation and de-escalation. So in de-escalation, you are essentially saying, I'm going to stop everything that is unnecessary. In other words, maintenance fluids, can I concentrate down the dilution for the drugs, etc., etc. With deresuscitation, you are actively removing fluid. So renal replacement therapy, diuretics, so on and so forth. That's the general difference between deresuscitation and de-escalation. Now the problem with this phase, again, is that we are so used to giving fluids. The blood pressure is low, we give fluids. The heart rate is high, we give fluids. The urine output is low, we give fluids. The lactate is 4, we give fluids. The nurse is walking up to me, I'm giving fluids. So it's almost too easy to give fluids. Whereas if you're going to talk about the latter stages, deresuscitation, the how and the knowledge is much more nebulous. But generally speaking, we are the how is usually around renal replacement therapy, and the use of medications such as diuretics, commonly frusemide. One of the things that you could use to do it is something called the frusemide stress test. Hands up those of you who have heard of this. So if this is essentially trying to predict if your patients with kidney injury is going to recover and start passing urine. And what you do is dependent on whether the patient is normally on frusemide or frusemide naive. You give either 1 or 1.5 milligrams of IV frusemide, and you watch for the next 2 hours how much urine output they produce. If they produce more than 200 mils of urine, generally speaking, the thought is they will recover. Okay? Other things you can do to try and bring your patient back down from a very, very positive fluid balance down to the more neutral balance is something called PALS. Professor Manu Malbrain, who's done a lot of work around fluid stewardship, so on and so forth, advocate PEEP, albumin, and frusemide. I have to say that we don't tend to use the PEEP side of things in my unit. We do use the albumin. We do use the frusemide. But the problem is trying to decide when are you going to deresuscitate the patient. As you've seen earlier in the graph describing the ROSE concept, the timing for one phase to the other isn't precise. And the other issue is that in an ideal world, we like our patients to come into our ICU, they're really sick, they get better, they go home. But we also know that in some patients, which may be a significant proportion, they come in, they get better, they pick up a hospital-acquired pneumonia, they get worse again, the surgeons decide to operate again, the surgeons decide not to operate again, and they go back and forth, back and forth. So the ROSE, although we've drawn it as a conceptual smooth line, it doesn't play out like that in real life. This is a really interesting study because to me, it underpins how easy it is to give fluid. This is by colleague Niels van Riggemorten. And what he did was essentially, he said, I am going to look at, on my intensive care unit, every single drop of fluid being given. And what are they being used for? Are they resuscitation, optimization fluids, you know, that sort of thing. So, and what he found was that the majority of the third of the fluids being given for the patients on his unit were what he called fluid creep. In other words, these were the fluids that were given without the intention of it being fluid. So these are your 20 mils of normal saline to facilitate the drug. It was your noradrenaline infusion. It was your propofol infusion, so on and so forth. All of this had a volume which are not calculated within it. So if you reflect on your practice in your intensive care unit, how much fluids are your patients getting? Do you know how much fluids your patients are getting? So have you even thought about the patient who is there on day 5? You look at your cumulative fluid balance chart and it says 7 liters positive. You look at his lower limbs and it's got peripheral edema. Would you actively consider deresuscitation? I have to put my hand up and I say, well, if he's breathing 24% by nasal cannulas, there is no noradrenaline infusion, I do nothing. But is that harmful? Is that good? Is that good practice? It's deliberatable, but these are the signs that we normally use when we say this patient has got too much fluid on board. So you lose things such as the blood pressure, you can look at the chest x-ray, disclosures of interest. My other area of interest is ultrasound, so I'm going to show you some ultrasound pictures around it. You could do the reverse of what Professor Langroy said, which is instead of looking for fluid responsiveness, you could use the absence of fluid responsiveness as your marker of perhaps it's time to take fluid off. But the problem is that of all the myriad of tools that you can use, we don't use it consistently. So this is a really nice article published by colleagues in Belfast and Canada. It's the RADAR-1 study. And essentially what colleagues did was they put a couple of scenarios to critical care practitioners. And they said, in this scenario where the patient is fluid overloaded, what would you do? What parameters are important? What treatment would you institute? Now the take-home message from these next 2 slides is that we use very different parameters We give different levels of importance to those parameters, and we also do different things. We watch out for different types of complications. So in other words, in terms of deresuscitation practice, at least when this survey was conducted, there is a huge degree of variability in practice. Huge degree of variability in practice. So again, thinking about the parameters, you can use any one of these. Any one of these. Colleagues would argue clinical parameters are the best, but when you assess edema, say, do you grade it the same way? Do you clock it the same way as your colleagues who work in the same intensive care unit? Because if you don't, then potentially you will do different things to the same patient in the same ICU. Just for the sake of argument and sake of deliberation, how many of you have seen this sort of chart before? This is body impedance tomography. Essentially, it's passing small electrical currents through electrodes to different, it's like a modified ECG, essentially. But it's able to tell you the different body compartments through measuring the resistance, so on and so forth. We have this in my unit, but it's mostly experimental at this moment in time. We do not use this routinely. What we try to do is something similar to what Professor Marbrain put, which is, generally speaking, after day 3, generally speaking, if the patient is having an appropriate trajectory, we try to minimize how much we put in and try to bring the patient back down to neutral fluid balance. Hands up those of you who have ultrasound on your intensive care unit or anesthesia department. Okay, that's the minority. One of the things I like about ultrasound is that one is cheap, relatively cheap. It's non-radiation. You generate a picture, and generally speaking, everyone can look at a picture. And some of the measurements there are more consistent and therefore more objective. So things that you can do to guide whether your patient is overloaded or not, you can look at the IVC. I put it there not because I like it. In fact, I absolutely hate it. But it's one of the more established ones in terms of ultrasound parameters. Hands up those of you who do this, lung ultrasound. The sensitivity and specificity of lung ultrasound far outstrips that of clinical examination and chest radiograph. It also tends to be more reproducible, and the inter-observer variability and scoring system tends to be better with ultrasound as well. And the last bit of ultrasound I'm going to mention is this one. Hands up those of you who've seen this. This is something called VEXIS. Essentially, what the principle is, it's using ultrasound Doppler techniques to look at the venous side of the circulation, which is a shift from what we normally do. Normally, we are focused on the arterial side of the circulation. We like to look at the cardiac output. We like to look at the stroke volume. We try to optimize the stroke volume. We look at the arterial blood pressure, be it systolic, mean, and diastolic. The venous side of things, if you're lucky, you've got an appropriately transduced central venous pressure. If you're really, really lucky, someone's actually looking at the waveform of the central venous pressure. This essentially takes it one step further by looking at the venous vessels leading into the IVC, ultimately into the right heart. And it comprises of looking at the hepatic vein, portal vein, and the veins within the kidneys itself. For those of you who are interested, we're doing a couple of workshops tomorrow on the topic of this where you get some hands-on practice. And again, to sell the ultrasound point, using this as a rough schematic, which is, this slide is from my colleague and friend Cosmin, who works in Bucharest, but with ultrasound, with echocardiography, you can look at the stroke volume and measure stroke volume responsiveness. With the other probes attached to the ultrasound machine, you can then look at the venous side of the circulation. What is the lung congestion like? What is the congestion like in the hepatic vein, portal vein, and so on and so forth. So when you put it all together, this trial came into place. Now, the reason why I'm mentioning this trial is that up until now, a lot of the trials looking at deresuscitation versus conventional practice have not been shown to be of benefit. But one of the problems with these trials is that they fail to get a degree of separation between your control and intervention arm. So if you haven't achieved a separation in fluid balance between your control and intervention arm, then you might not find a difference in the mortality. And that's what the trial showed. The RADAR-2 study I want to highlight because it was one of the recent trials which looked at, I am going to look at the feasibility. So I'm going to aim to get separation between the control and intervention arm. And this is what they did. So essentially, they're saying the minute this patient comes to the intensive care unit, you should be very, very mindful of what fluids to give. You should be assessing daily for whether this patient would be eligible for deresuscitation or not. And the criteria they are using is this. So fluid access, edema, and then accumulated fluid balance. And then the contraindication, which are essentially markers of malperfusion. So is the lactate okay? Is there a NORAD requirement that's excessive, so on and so forth? If they haven't got it, you're going to deresuscitate them. And when I looked at this paper, I was quite shocked because if you look at what the intervention arm is, in other words, the arm designed to get the negative fluid balance and achieve the separation, is extremely aggressive. Extremely aggressive. They want 2 liters down using a frusemide infusion, spironolactone, indapamide, and if they fail to do it, they go on renal replacement therapy. So that doesn't happen in most hospitals in the UK. It certainly does not happen in my hospital. But what they showed from this trial was that it's possible. And the safety profile is comparable, but it's extremely aggressive and therefore resource consuming. But other people have shown it and used this sort of principle before. This is another one looking at renal replacement therapy. I'll give you a copy of my slides if you're interested, but essentially they're using different markers to see how quickly they can dry these patients out, assessing for safety profile as well. Not much difference in terms of the lactate, or no difference in terms of the lactate and norepinephrine and all the markers of things that you think might be bad if you aggressively take fluid off. Don't worry about this one. Just to highlight that all the trials so far, this is in trials looking at septic shock. The current evidence suggests that there's no survival benefit to active fluid deresuscitation compared to usual care in patients with septic shock. The European Society of Intensive Care Medicine recently published their Part 3 guidelines. This is Part 3, which is deresuscitation. Part 1 was resuscitation. Part 2 was what type of fluids to give. So this is Part 3. Just to highlight the main findings, that essentially there is very, very little evidence base out there in terms of what to do. The experts' consensus seems to suggest that deresuscitation is probably a good thing. We should probably be using diuretics before going to renal replacement therapy. But that's about it, really. The evidence base for all these recommendations are really, really poor. And again, I've just summarized it there for you. Probably the thing that has changed, that will change the landscape of future trials and therefore our practice is, I think it's fair to say that we now know and practice fluid responsiveness testing, whether you do it in doing passive rate race tests, whether you do tidal volume challenges, whether you do a mini fluid challenge, whatever. The concept of fluid responsiveness and measuring fluid responsiveness is now a thing. How many of you heard of fluid tolerance? It's a relatively new concept. I think it's just a repackaging of what we knew before. And essentially what it's saying is, simplistically, if fluid responsiveness is the potential for benefit, simplistically fluid tolerance is a degree of harm that the fluid might cause. How well can your physiology tolerate that fluid? And the reason why I bring it up is because, again, conceptually, we seem to like that we have fluid responsiveness on one side, fluid tolerance, fluid unresponsive, fluid intolerance on one side. So between these 2 points, they are joined, and whether it's joined by a straight line or a U-shaped curve or a W-shaped curve, they're joined. But this study, and there are other studies like it now, which essentially shows that the states can coexist. So instead of just 2 points, 2 types, you can have 4. So you've got the 2 that we've established already, but you have some patients who are fluid responsive and fluid intolerant, fluid unresponsive, and fluid tolerant. It depends on how you assess and whatnot. So I suspect moving forwards, as this becomes more established, more and more people will research it, use it, and so watch this space. So to sum up then, I think it's fair to say that too much fluid is a bad thing. I wish I can say to you, go back to your intensive care unit and look at this parameter. Probably it won't be there. And deresuscitation is an evolving thing, so again, watch this space. Thank you very much.
Thank you, Adrian. Please stay there, and I invite Ruslan to join me. Thank you, both of you, for allowing 15 minutes for discussions and questions. Dacă aveți întrebări și vreți să le formulați în română, o să le traduc eu dacă nu vreți să vorbiți engleză și viceversa. Deci, cine începe? No questions, no comments? Întrebarea mea pentru asta este cine utilizează sau parțial sau total asta ecodoplurul venos pentru ceea ce Fizi a prezentat, asta cu Vexus Score. Ok? Și ceilalți? No? Adrian, there's a question. So we sent a few articles, we discussed with some of my colleagues. The issue is as follows. The Vexus Score has been used for the first time in cardiac surgery. Outside of the cardiac surgery ICU, what is your impression about the validity? And a second related question is, because the renal venous Doppler is fairly sophisticated, what would be the minimum components of the Vexus score that you would actually recommend for non-specialists to use?
Okay, so for those of you who didn't read the paper, as Dan mentioned, the Vexus score was developed in cardiac surgical patients. What happened after that was uncontrolled proliferation of the use of that Vexus score. So people started using it in all sorts of different patient settings that were not intended. The initial paper, they excluded anyone with sepsis, they excluded anyone with renal dysfunction, they excluded anyone with liver dysfunction, they excluded anyone with renal dysfunction. So essentially, every single patient on your ICU would not have been included in the paper. However, having said that, people have reined themselves back and started doing it, in inverted commas, properly. So there are some work coming out from your neighbors in Romania which looks at the various different components of Vexus. We think the one that's generated most interest is the portal vein one. Okay. So for those of you who don't scan regularly, the portal vein, in my humble opinion, is not too difficult to do. You can use it with your cardiac probe. However, I would never recommend people just scan Vexus or do venous congestion Doppler by itself. Like everything that we do, we're looking after a patient as a whole. So I would recommend people to have a look at the heart first, IVC, lungs, and then if you're that skilled and you had the appropriate training, do the portal vein. If I had to pick one, but I would say look at the heart first, because you can get a lot of information.
Fully agree. So we're not